Well, over the last 20 years, we've seen an area of breast cancer that didn't exist 20 years ago, which is HER2-positive breast cancer. 20 years ago, we were just starting to appreciate that this was a distinct entity, and even though we recognized that, we didn't necessarily have much in the way of therapy that was different than any other kind of breast cancer. So the last 20 years have seen an explosion of therapeutic options for physicians and obviously for patients that has resulted in a completely different way the disease is treated. And furthermore, it's improved the outcomes remarkably, both in patients with advanced and early stage disease. Similarly, for anti-hormonal therapy, we had a couple of options 20 years ago, but the number of options has expanded significantly. And the thing that has changed most recently is partnering anti-hormone therapy with targeted therapy, which has resulted in markedly improved outcomes. And these kind of therapies are now making their way into the adjuvant setting of ER-positive breast cancer. And in some ways, the last frontier where we've chipped away but not necessarily made a staggering improvement in outcome are so-called triple-negative breast cancers, which we have heard throughout this meeting is not a monolithic entity, but a variety of different diseases under the moniker of triple-negative breast cancer. And part of the challenge is trying to figure out what are the drivers in each of those entities within triple-negative breast cancer, trying to identify therapies that can enhance the outcome. And one of the therapies that appears most promising, again, won't be a home run, but it'll be incrementally improve the outcome, is checkpoint inhibitors plus chemotherapy.